Hello, my dear doctors. So, today we're going to discuss a bit about the neurology station, and I'm going to give you some tips about the cerebellar syndrome. This case is also quite common in the neurology station, and if you see the patient and you think that you got cerebellar syndrome, there are a few things to look for. So let's discuss the cerebellar syndrome today. So when you're asked to examine the patient lower limbs, well, it is a good technique to start by asking the patient to walk for you before even the examination started. So once the patient walks and you look at their gait and you identify specific gait patterns, so it will make the rest of the examination quite easy. You can pick up your diagnosis right away. If the patient has an ataxic gait, patient tend to sway to right or left and will be steady on the, if you ask them to stand on one leg, and so it will be an ataxic gait, broad-based gait actually. So if you ask the patient to walk first and notice they have a broad-based and ataxic gait, so you have your diagnosis even before proceeding to the rest of examination. So in this case, you know already that this is cerebellar syndrome. So going to do the whole CNS examination, but you will be particularly focusing on the cerebellar signs for the rest of your remaining time. So what are the findings which we look for if the patient has a cerebellar syndrome? First of all, the gait I already discussed. The gait will be broad-based and ataxic. So if there is a unilateral cerebellar disease, then this would be associated with the tendency to fall to the side of the cerebellar pathology. Suppose if the patient is unable to walk without crutches, then just observe the way the crutches are held, as they would be broad-based in this case. Very important thing that Romberg sign is negative if you're dealing with a purely cerebellar syndrome. Next thing you look for is the speech. Normally, patients who have cerebellar syndrome, they have a slurred or we call it staccato speech. So we can ask the patient to repeat a few phrases like 42 West Register Street or baby hippopotamus. Then you like to look at the eyes. You may find on the monitor there is nystagmus. And remember that if you see nystagmus, the fast component will be on the site of the cerebellar pathology. And the saccadic eye movements are abnormal, will be hypermetric. Moving on, once you do the upper lip examination, you will be looking for a dysdiadochokinesis. There will be dysmetria on finger nose testing and intention tremors. And they'll be rebound when the eyes are closed. Same findings you'll find for the cerebellar syndrome. In the lower limbs, there may be impaired heel shin testing and pendular reflexes. So remember that if the patient has a cerebellar syndrome, so this is just your findings. You want to try, you like to look for the cause. Why this patient has this cerebellar symptoms. So once you identify the pattern as bilateral cerebellar syndrome, then you'll be thinking about all the differential diagnosis of the cerebellar syndrome. So we'll proceed to look for quick clues that you can spot within your 6-minute examination. So what are the probable clues will be? Suppose if you find on eye examination patient has internuclear ophthalmoplegia, then you'll be thinking about demyelination like multiple sclerosis. Suppose if the patient has any chronic liver stigmata, maybe a palmar erythema, Dupuytren's contracture, gynecomastia, maybe got SITs, then you'll be thinking about alcohol. Then if the patient has a pyramidal weakness and impaired vibration, means that you find dorsal column sign, then we'll be thinking about Friedreich's ataxia. And then There are some medicines also which can cause cerebellar syndrome, so we will discuss it later. So medication may be at the site of the bed, so just it's a very important thing that you inspect the surrounding of the patient and look for any possible clues. Suppose if the signs are unilateral, so then after presenting your findings, you may want to say to the examiner that you would like to do the brain imaging in the form of MRI, because to search for the cerebellar lesions. And cerebellar lesions may be vascular or infective etiology. So how you will present the case? I prepared a model presentation for you. The patient, you will start with, it's very important once you have a spot diagnosis, just give your diagnosis first and then later on give some other details. This patient has signs of bilateral cerebellar syndrome. Then you will going to reinforce your diagnosis by saying that on examination of his upper limb, there is this diadochokinesia with intention tremor, and there is dysmetria on finger nose testing on both limbs, and this is more marked on the right or left, wherever. Similar findings are evident in both lower limbs, as the heel shin test is impaired in both limbs and is more marked on the left. You will mention about the gait. On walking, the patient adopts a broad-based gait, which is characteristic of cerebellar syndrome, while Romberg's test is negative. And you will conclude by saying that I like to finish my examination by performing the cranial nerve examination, obtaining a full history, including the medication history and alcohol history. So when doing the presentation, just try to be systematic and take your points one by one, so that it's easier for the examiner to understand. So then how would you investigate this patient? The examiner may ask you that about what is your plan or how you investigate. So remember that in cerebellar syndrome, the first priority is to look for the cause. And because we want to look for the cause, because if we can found, they may be reversed by treatment. All patients with cerebellar syndrome will need brain imaging to exclude the obvious cause, and a series of blood tests should be sent. We want to do the full blood count, biochemical profile, inflammatory markers, full antibody screen, hematinics and thyroid function tests will be the initial screening, so we're going to do all the tests. A full neurological examination is essential, and then we have other tests like if you cannot find the cause, like CSF analysis, or more specific blood tests may be needed if the initial screen has failed to reveal a cause. So briefly, what are the causes of cerebellar dysfunction? It's very important if you memorize it by dividing into different groups, like we have hereditary causes, in which we have spinocerebellar ataxia or Friedreich's ataxia. They can be congenital malformation like Dandy-Walker syndrome. And then there are acquired causes. Acquired causes, degenerative causes, which can happen in MSA, any tumors in the cerebellum, which creates like medulloblastoma or astrocytoma. They can be systemic causes like alcoholism or hypothyroidism, and some of the drugs like lithium and phenytoin, and especially their exposure to toxins like heavy metals or carbon monoxide. So they are hereditary causes, we have congenital malformation, and then we have acquired causes. So how would you treat this patient? So the management option actually will depend on the underlying cause. If the cause is treatable, then this will be the target of treatment. However, now if the cause is not reversible, as in most cases, then the patient should be managed via multidisciplinary approach with supportive treatment for symptomatic control and psychological support. So I think that's all about the cerebellar syndrome. I hope that it will be helpful for your PACES neurology station. Thank you very much, and see you soon in my next presentation.